Right, the oxygen carrying capacity, right? And what are some of the symptoms of anemia? You got them. All right, cool. All right, so again, we'll start today on the microcytic anemias. Micro meaning what? Right, small RBCs, right? So less than 80. All right. You guys know the objectives, Yahoo stuff. All right. So, big part of anemia, and what would you say was the most common cause of anemia? Iron deficiency, right? So you gotta understand and have some understanding of iron metabolism as we talk through some of these. They're the key microcytic ones that we're gonna cover in this class. Anemia of chronic disease and inflammation. So a little bit micro, a little bit normocytic. And we'll talk about that one specifically. So when we get to chronic disease, because it starts out normocytic, normochromic, normal size, normal color, normal pallor. But if anemia of chronic disease goes on for a long time, it can become microcytic hypochromic. All right, iron metabolism. Iron, important nutrient. We kind of talked about this a little bit already, right? So it plays a lot of roles. Certainly with hemoglobin, it's part of that hemoglobin structure. But also it plays roles in, skin, hair, nails, all this other stuff, right? Essential for oxygen transport, the hemoglobin we talked about. Supports DNA, sure, immune function. And then daily requirements. Key here just being, hey, women need more iron. Why is that? Menstruation, they're losing all the time, right? So they're always a little bit behind the power curve. And then you need more iron in physiologic states where pregnancy, growth, right? The body just needs more. Right. Dietary iron, right? Heme iron. What are we talking about there? Yeah, so meat, poultry, fish versus non-heme. Right. So which one's better? Yeah, right. And a lot of people go through all these little diet trends and lifestyles. For some people, they're truly committed, right? Vegan for life or whatever. And you have to think about that too when you're getting your patient histories. This person's set up for some sort of deficiency just because of the way they eat. And then factors that enhance, they used to say, hey, if you're going to take the iron pills, whatever, take it with something acidic that helps the absorption. Right. Iron absorption takes place in the duodenum. Transport, bound to transferrin, and we'll talk about these iron, transferrin, and all this other stuff in a minute. So one thing you're going to realize, so iron is almost always bound to something else when it's in the body. Iron is very reactive if left on its own, which will cause free radicals. And what does free radicals do to the body? So it oxidizes stuff, right? It causes stress on the environment, stress on the body. So iron, to prevent that from happening, is almost always bound to something, like transferrin or stored as ferritin, something else. And this is just to kind of say, hey, where's iron in the body? You see the majority of it is actually with it in the RBCs, right, in that hemoglobin. Ferroportin, hepcidin, hemosiderin. All right. So you got to understand what's going on with these first two here. So where in the body did we say iron was absorbed? Duodenum. So in the duodenum, in order to get that iron transported across the duodenum, across the intestinal wall, into your bloodstream, you have something called ferroportin. Ferroportin is the door. It's the door that lets iron into the bloodstream. Hepcidin shuts the door. When the body, for whatever reason, hey, we don't need any more, we need to slow this down, we need to stop this hepcidin. When it's elevated, it's going to shut the door, so the body's going to absorb less iron into the bloodstream. Ferroportin's your door, hepcidin shuts your door. Right. hepcidin produced by the liver regulates iron absorption. High levels, it's going to decrease the amount of iron coming into circulation. It's going to decrease the amount of iron that's available to the body. Low hepcidin, yep, then it's increased. Yeah, exact opposite, right? One of the things, and we'll talk about this when we talk about anemia of chronic disease. In inflammatory states, high inflammatory states, the body increases the amount of hepcidin. Okay. All right. So you can walk. Never mind walking the dog on this book. I learned my lesson. All right. So you can see here in the duodenum, right? We talked about where iron gets absorbed. And across that membrane would be the ferroportin, right? That's going to open up, get into circulation, work its way around, and you can kind of see if you go through these, ferritin is stored, right? It's transported on transferrin, but this kind of works the whole iron absorption system. Iron, yep. So deficiencies, right? What's the cause of deficiency in iron? Blood loss? Sure. Poor dietary intake. Yep, they're just not taking enough. Malabsorption. Hey, they're eating all the iron, everything, right? Big lean leafy vegetables and everything else, and meat products, but because they have a malabsorption problem, right? They're still low in iron. The symptoms, we all know these by now. And then iron overload. Hemochromatosis we'll talk about as its own disease process in a minute. And TIBC, so lab values, right? Total iron binding capacity. High in iron deficient states, low in chronic disease. So their body's ability to bind iron. So if the body is low in iron, what happens to your TIBC? Goes up, right? You have increased ability. Transferrin saturation, that's the ratio of iron to TIBC. These will touch on a little bit. More iron stuff. All right, okay. So ferritin, what's ferritin? Stores, right? Ferritin is the measure of the body's stores of iron. TIBC, we said, hey, if your iron is low, then your body's ability to bind it increases. Right? So the body wants more. There's your TSAT levels and then your receptor levels. You gotta be able to interpret some of these stuff, right? Ferritin, TIBC, in different disease states, where they're going up, down, you gotta be able to figure that out. And there you can kind of go a little bit of a chart, right? So serum iron low, iron deficiency, you can kind of see what they're doing. What's your transferrin? Transport. Right? So again, iron, right? Traveling in through the circulatory system, you don't want it out there, so it's bound to something. It's bound to transferrin. Right? And what's it stored at? Ferritin. All right. Iron, critical for oxygen transport. Why? What's iron a part of that's necessary for oxygen transport? Hemoglobin, right? Regulation of homeostasis, yep. Imports of hepcidin, yep. Common disorders, iron deficiency, iron overload, and then lab tests. Any questions on the iron basis to this point? Everybody good? Fish? All right, fair enough. All right, so microcytic anemias. So we talked about this a little bit. We touched on the approach to anemia, right? Hey, based on what labs are you going to say somebody's anemic? You run your CBC, you get your CBC back. What are you looking at? Looking at your hemoglobin and hematocrit, right? RBC's hemoglobin and hematocrit. They're all going to kind of tell you the same thing. Most people kind of look at hemoglobin pretty quick, right? So hey, You decide, yep, patient's anemic. Next what? What are you looking at for next? So yeah, so by the book, right? Retake. Real world, right? I might not have that retake on that initial one, depending on where I'm running my CBC. So I'm looking at my MCV, right? If I look at my MCV, it's gonna tell me what? Am I dealing with a microcytic condition, a normocytic condition, or a macrocytic condition? Right? What's the value of your retake? What's the retake tell you? Right, so hemolysis or hemorrhage, right? Hemolysis or hemorrhage. So hey, so you run your CBC, you say, yep, anemic. Look at my MCV less than 80. Now I know I'll deal with a microcytic condition. Right, so in your brain, you start with what are my differentials for a microcytic condition? Iron deficiency would be at the top of the list, right? Thalassaemias, right? Alright, retakes. So alright, so hey, you know what? I called the lab, I added a retake, I got my retake count back. Right, and you can kind of look and kind of see, low to normal, I follow this pathway, but what am I dependent on at this point? My iron studies. Right, I'm looking for my iron studies. So again, being that iron deficiency anemia, #1 cause of anemia, certainly you think of it when we think of a microcytic hypochromic problem. What's hypochromic? Yeah, so that when we look at the blood cell on a microscope, you'll see that central clearing, right? It's more than it should be. Right? Again, just not as concentrated, it's not as much hemoglobin in there, right? So they refer to it as a microhypo, right? Iron deficiency anemia. Microcytic hypochromic. And going back to your retake counts, low to normal. Yeah, I'd get my iron studies next, right? I got irons to figure out what's going on with the patient. If it's increased, what do we say the problem set is if it's increased? Hemolysis or hemorrhage, right? And you can kind of go down that pathway there. So iron deficiency anemia. Is my iron high or low? Low. It's iron deficient, right? Is my ferritin, which is my what? My stores, is that high or low? Low. It's iron deficiency anemia. And my TIBC, high or low? High, right? And you can kind of follow any of these pathways here, and you can kind of figure out what's going on. But once you get that right, you need those iron studies. So if you're working this patient up, yep, I know they're anemic, I look at the MCV, I know they're microcytic, right? I'm dealing with a microhypo problem. Right, at the top of my thing, I gotta at least take off of my differential is, are they iron deficient? And how are you gonna determine if they're iron deficient? You're gonna hire your iron studies, right? Alright, you guys are good. Alright, what's microcytic? I think we beat this to death, right? Anemia, small RBCs, less than 80. Common disorder, yep, hemoglobin synthesis. Caused by defects in the hemoglobin. So when you think of the microcytic problems, think of all of them as there's a problem with the hemoglobin. Right? In iron deficiency, I'm lacking heme. Right? When I talk about sideroblastic anemia, there's a problem with the protoporphyrin ring that makes up your hemoglobin. When you talk about the thalassemias, where's the problems at? The globin chains, right? But there's any other microcytic anemias, you can trace back to a problem with your hemoglobin. Right? And what are the components of your hemoglobin? Heme, right? So that heme, that iron deficiency anemia, okay, that's the problem set. Sideroblastic anemia, that protoporphyrin ring that holds the heme, there's your problem. Something wrong with the protoporphyrin. You go to your thalassemias, the problem set is your globulin chains, your polypeptide chains, your globins, right, from the heme. Got it, all right. Iron deficiency, most common, anemia of chronic disease, which is now like also called anemia of inflammation. Like you see, anemia of chronic disease is kind of an oldish term that we still use, but it's also now anemia of inflammation. Sideroblastic anemia, we said, hey, defective heme synthesis. Thalassemia is genetic disorder affecting the globin chains. And then lead poisoning, again, disruption of the heme. So all these microcytic anemias, what they have in common, there's a problem with the hemoglobin itself. Iron deficiency, you guys know this already. Most common cause of anemia worldwide. Most common nutritional deficiency. Low prevalence and severity in the United States, right? Bunch of iron fortified food everywhere, right? Everybody adds everything. But problem in certain subsets of populations. Toddlers, kids, adolescent women, women of childbearing age. Why toddlers and adolescents? Why toddlers? So diet and then growth, right? There's a demand need, right? They're growing. So you need it. Adolescent girls, what's the problem there? Menstruation and growing too, right? And the menstruation combined. And women of childbearing age, right? Still menstrual issues, right? More frequent in females is right there. Must consider occult sources of blood loss. So in the right population, your right patient, right? So I have a 65-year-old female who's trucking along and wasn't really iron deficient, and now you got her in and she's severely anemic, and you run your iron studies and you say iron deficient. What are you concerned with? So potential gastric bleed, or what's the other one? What's the one you can't miss? I think you can't miss a GI bleed. Cancer, right? What's causing that bleed all of a sudden, right? Cancer, right? Is there cancer? That's cancer till proven otherwise, right? So in the right population, so elderly person, I say elderly like my age, right? So whatever, right? So I'm older, let's call it that, more experienced person, right? Who doesn't have a reason to be anemic, like, you know, women of childbearing age, menstrual cycle, they got a reason. And now, hey, I got a 65-year-old who's probably not having a menstrual cycle anymore, right? And all of a sudden she's an iron deficient anemia. What's going on? Why is this person anemic? You got to take cancer off the table. That's cancer to proven otherwise. Right? So what are you going to order if you're worried about cancer in that patient? What are you going to order? Colonoscopy. Right? That patient needs a colonoscopy. Because you got to prove that that patient doesn't have colon cancer. All right, there we go. Iron deficient, yep. Dietary sources we talked about, absorption, duodenum, and then what facilitates that transport, right? That ferroportin opens it, it's sort of the doorway. Hepcidin will close the door. Distribution, most of the iron is on the hemoglobin. Some of it's stored as ferritin, a little bit myoglobin. Hepcidin levels rises in inflammation. So when we talk about anemia of chronic disease, you're going to see why this high inflammation is going to increase your hepcidin, which is going to reduce the body's availability of iron. Iron deficient, right? You guys good with this? Decreased iron stores, right? You can't synthesize, you can't make enough hemoglobin, enough good hemoglobin, right? Microcytic anemia's problem said again is the hemoglobin. All right, stages. Depletion of iron stores. So now the iron stores are decreasing. You start to see that in your what lab value? Your ferritin, right? Iron stores are going down. And then eventually it goes down to the point now where the body just doesn't have enough to make the red cells normally. So you get that second stage, impaired erythropoiesis. Right. And then the end result is a microcytic hypochromic anemia. Good? And then the causes, we've talked about most of these, right? Hey, is it blood loss, whether it be GI, menstruation? Is it just not taking in enough? Or is there a malabsorption problem? Supply versus demand problem, right? Depending on how you want to look at it. You can look at it as a supply versus a demand problem. Supply, Yep, they just lack the nutrition, not taking it in, restricted diet, right? Or yep, they're taking it in, but they just can't absorb it for whatever reason. Or is it a demand problem? Is it, hey, the body actually needs more, right? These high physiological states, growth. And then loss, right? Peptic ulcer disease, whatever. Hookworms, right? Does this person have a parasite that's leeching off of them, and that's causing them to be anemic, right? Depending on where you are in the world, right? And you guys don't deploy or go anywhere exotic ever, right? Wrong answer, right? So could you see this? 100%. Could you see it in the US? Yes, right? And then colon cancer and polyps, right? So again, in that right patient population, you gotta take cancer off the table. Don't miss that one. Right? Hemolysis, and we'll talk about some of these disease states specifically, right? Iron deficiency, we're gonna beat this to death, right? Major cause, there you go. Right, so your blood loss, is it a nutritional intake problem? Is it a demand problem, do I need more, right? And then any of these conditions over here, impaired absorption, right? Parasitic infection, hookworms we talked about, frequent blood donation, which you could potentially see, not unheard of, not common, and certainly not common in military people necessarily, but you have these people that go and donate so much. I go and I donate, I'll get some money. Right? So part of our rotation, you go out to San Diego for Navy, we do our ER rotation and our trauma rotation downtown San Diego. Right? You can get an indigent population, a lot of homeless people. Right? And people who have to come in and would drive you nuts because a lot of them are drug seekers, and you gotta deal with these people and figure out, right? Because everyone will come in and say, you know, that Motrin doesn't work for me. No, that morphine doesn't work for me. The D drug, I need the D drug. Right? That's the only thing that works for me. What's the D drug? Dilaudid. Right? And they're not leaving your ER till you get them a shot of Dilaudid. Right? You gotta figure out, am I or am I not? All right, more loss, increase, right? So there you go. Epistaxis, sure, varices, you name it. Right? Anything that could cause you to lose blood. Trauma, obviously, good. And then absorption problems. Let's see, antacids, bowel resection, yep. So again, absorption, and then just intake issues, right? So for whatever reason, supply problem, demand problem, you're just not getting the iron you need. Presentation, sure, variable, right? But if we're talking anemia, and we all know anemia presents how? Right, some version of that, right? The fatigue, the weakness, the headache. Right. Or in case of iron deficiency anemia, and some of these other anemias even, a lot of times your patient is asymptomatic, right? Especially if it's early on in the disease process. Sometimes they'll be asymptomatic, and it's something that you're gonna catch just an incidental finding. Right? Your patient's in for some routine, whatever, physical, you order a CBC, come back a little bit anemic, right? Now you start going down that trail of why is this patient anemic? And sometimes the patient never realize they are at that point. Or if there's a patient so far along in the disease process that they're already showing symptoms. Pica, we talk about koilonychia. What's koilonychia? Right, that spooning of the nails, right? And then restless leg syndrome, they don't know why this is exactly, but iron deficiency anemia has been associated with restless legs. And then at the bottom says there, yeah, maybe asymptomatic. There it is. There's your classic koilonychia. All right. Lab tests. We're talking about anemia, so our CBC, you expect our hemoglobin and hematocrit to be what?
So with the restless leg syndrome, I guess I'm thinking that with iron deficiency, you want to
So that's as good as any explanation I've heard. Right? So to be honest with you, so there's a lot of research out there where they're trying to figure out, and they don't have a great answer for what the correlation is, but there's been an obvious trend to show that people with iron deficiency have a higher degree of suffering from restless leg syndrome. There's a bunch of research out there trying to, right? Everybody's trying to make $1 million, figure out why, right? And that's as reasonable explanation as anything anybody else has said. Alright, so hemoglobin, hematocrit, again, your anemia, we won't beat this up too much. MCH, MCHC, alright, your MCV is low. Retic count. Do you expect your retic count to be high, low, or normal? Just not high. Could be normal, could be low. High is gonna suggest what? Hemolysis or hemorrhage, right? So if it's true just iron deficient state, you expect it to be not high. Right? Iron studies, ferritin. Ferritin's your storage, your ferritin is low. Right? Ferritin less than 15 is almost always iron deficiency anemia. Serum iron, sure, low. TIBC, we said high, and transferrin, SAT. So the SAT, your transferrin is your what? Transport, right? So in iron deficiency anemia, obviously your transferrin is not a saturation, it's not full, right? There's room on the transferrin. And then your peripheral smears. So this is what we're talking about. And you can take a look at this slide. It's a little bit hard to see probably, but microcytosis, right? So the cells are small, and I don't have a good reference one in there to show you, except for the WBC, and RBCs are typically smaller anyway, but very small, and then hypochromic. You see how pale that cell is in the inside? Right, that's your hypochromic. Anisocytosis, what's anisocytosis? Different size, so variation in size, right? Because sometimes what will happen is you have a population of cells that's still somewhat normal, right? And then you have those microcytic ones, so you have a variability in size, and that's anisocytosis. So you won't know that anisocytosis until you get what? Manual diff, right? Because that's somebody looking at a peripheral smear, again, some lab tech weenie, staring in a microscope, right? Looking at it, it's going to say, it's going to come back on your manual differential, 2 plus anisocytosis, 3 plus anisocytosis. That's going to tell you the degree of variability. Right? More of the same, right? So this is just another slide to kind of talk about what you can expect your iron and your iron studies to be. Right? I would be very familiar with this kind of thing, right? Because again, you need to be able to diagnose based on your studies. All right, I realize this patient has, here, on the test and in real world, here are some CBCs, you ordered your iron studies, here's your iron studies, can you interpret those iron studies? Management. They're iron deficient, so what am I going to give them? Iron. Right? Ferrosulfate. Give them some iron. Right? And if it's a dietary thing, right? This is a conversation with you and your patient, right? Because some of these people, they're not going to change their diets regardless. Some of them, you can have a conversation, hey, you need to change your diet and do X, Y, and Z, and be like, yep, no, sorry, right? All right, well, you're going to be iron deficient, so you need to take iron. Right? Having that conversation. Severe cases, intravenous iron therapy. So if you have to give somebody IV iron, it's painful, and it takes a long time because it's slow infusion and the life sucks for them. So most people are not going to want that. Address, sure, definitely, right? So if they have, what you need to figure out in your mind, why are they iron deficient? Was there underlying bleed or some other severe disease process? Again, in the right population, if it's a cancer, right? So I get my colonoscopy so I can sleep at night, I didn't miss a cancer, right? I worry about a bleed, right? And again, maybe another colonoscopy, right? Hey, let's rule out a bleed. Maybe an endoscopy, what it is, but I need to make sure I rule out a bleed. Get them on iron. And we'll talk about some of the stuff with iron. Anybody, well, so iron is not a fun thing to take, right? There's a bunch of side effects associated with it. And again, that's something you guys gotta figure out. I don't know how much they talk to you guys with this in pharmacology, right? So no medicine is benign, right? There are potential side effects or anything, and we willy-nilly give people medicine all the time. Oh, this will take care of you. Are we causing another problem set? Right? You always have to think about that stuff, especially on your patients that are polypharmacy. Right? Because many patients aren't on one meds or two meds, right? And if you go someplace and you have an older population, a bunch of retirees, right? So straight out of PA school, sent me to Yuma, Arizona, right? Clinic, nothing but retirees, nothing but retirees, right? And everyone would come in with a paper bag and said, I need a refill of my meds, right? And you would start going through this bag, and you're pulling out 6, 7, 8 different meds, right? And you're like, if I add one more med to this, am I gonna cause a reaction and kill this person, right? And I'm living on up-to-date, like, cross-reactivity, so crap, right? I'm gonna kill somebody. But you have to think about, no med is benign, and when you start polypharmacying people, right, your chance of an interaction and badness is a real thing, right? So don't willy-nilly give people things that we even think are benign. Because even putting somebody on iron could cross-react with other meds too, right? So just always kind of do your due diligence. Yeah, so you got them on iron, you expect to see improvement in the hemoglobin 4 to 6 weeks, right? Continue treatment for 3 to 6 months, replenish. So I start them on iron, I bring them back a couple months later, check their labs, see if things are moving in the right direction. Again, nothing's benign. Some of the side effects: constipation, abdominal pain, nausea, dark stools, right? Are people gonna wanna take their iron? Probably not, right? So patient compliance is a thing, because some people are just gonna give up on it. The side effects is worse than the problem, especially for a patient that was kind of asymptomatic, right? Now you said, you know what, you feel great, but you got iron deficiency. Here, you need to do this, right? Take this med, that's gonna make you constipated and give you GI upset, right? And yeah, so levothyroxine, what's levothyroxine? What are we talking about? Thyroid meds, and nobody has thyroid problems. That is a lot. Half your patients walking through your door, you're gonna be shocked how many people with thyroid. Yep, I got hyperthyroid. Everybody's on Synthroid, right? But again, stuff can react, right? So just kind of be mindful. IV, we talked about a little bit. So somebody's intolerant for whatever reason, or there's some severe whatever reason why you would want to do that. You really don't want to do that, and they don't want to do that because it's slow, painful. It's not fun. Malabsorption, though, hey, surgical resection. Right. Why in a patient like this you want to give them an IV? You can't absorb it, right? You had a resection. Where do you absorb iron? The duodenum. If they're missing half their duodenum, right, might be a problem set. They can't absorb it. Failure to respond, yes. And this is why I dislike people with a passion, right? Non-compliance, right? Patients lie. We all did it, we all lie, right? Patients lie, it's a thing, right? So always, right? When your patient comes back and said, yes, I've been taking my meds, give them that look in the eye, and are you really taking your meds, right? And in fact, how are they taking their meds, right? Is it, hey, I was taking my meds, but I was having GI problems, so I stopped taking it daily, and now I just take it once when I remember, right? Incorrect diagnosis. Yeah, especially with thalassemia. Thalassemia can fool you. Right? Microcytic, and we'll talk about some of the differences on the lab values a little bit. Thalassemia can fool you, and I've seen patients that were actually had a thalassemia, and nobody diagnosed it, nobody did the confirmatory test, and they were like giving them iron, and wondering why their stuff isn't getting better. Right? So if you start somebody on iron, and you draw their labs, and they're not trending in the right direction, then you got to start scratching your head and say, did I make the right diagnosis? All right, IDA, most important management, yep, ID, why, what's going on? Now you want to know the why. And then new onset, unexplained anemia, 50-year-old patient, we kind of talk about this. All right, that's badness till proven otherwise. You gotta be able to sleep at night. And for me, I gotta make sure I didn't miss a cancer. Right, so that patient population, new onset iron deficiency anemia, older male, yep, postmenopausal female, yeah, you gotta prove to yourself not cancer. There's your good old studies. Again, be able, I gotta figure out a new phrase other than walk the dog now, right? Be able to run the traps on this stuff, right? In your brain, iron deficiency anemia, iron is obviously low. My storage, my ferritin is low. Transferrin is my what? Your transport, right? So in an iron deficient state, your body's gonna put out more transferrin because it wants to carry whatever iron is out there. So your transferrin is gonna go up, right? If my transferrin goes up, my TIBC is going up too with it. Right? So the body wants to bind more. Right? All right. Any questions on iron deficiency anemia? Fairly simple, fairly straightforward. Right? So in your brain, what are the causes? Right? How would I manage it? How is the patient presented? And then be able to interpret the lab results. What is my CBC telling me? Okay, I'm worried about iron deficiency anemia. Obviously, I need to order my iron studies and work it from there. Anemia of chronic disease, anemia of inflammation. Again, so this is a disease process. We can cover more under the normocytic, but we'll probably breeze through some of it here. So it's a disease that often starts normocytic, normochromic. But if it goes on for a long time, it can become microcytic, hypochromic. Second most common cause of anemia. You have anemia of inflammation. You have primarily a diagnosis of exclusion. So to get to the point where I say this patient has anemia of chronic disease, it means in my mind I ruled out all the other causes. Right? It's like, it wasn't iron deficient anemia, it wasn't something else, I'm left with this. Okay? It's a diagnosis of exclusion. You need to take the other stuff off the table. All right. So we talked about Hep C a little bit. Right? In a state of increased inflammation, your hepcidin goes up. And what is your hepcidin gonna do? It's gonna shut the door, right? So all of a sudden the body can't absorb as much iron. We'll talk about the why there too. So hepcidin, yep, hormone produced by the liver and inhibits the iron release into, yep, you guys got that. So if I'm not getting the iron, then what? Yeah, so does it become a iron deficient anemia? Kind of. Right? And they can coexist, and often they do. All right. Clinical presentation, sure. So is there underlying, right? Anemia of chronic disease, is there underlying issue? Infection, and we'll talk about some of these things, but states of high inflammatory states increases your hepcidin. Right? So a chronic infection, that's a high inflammatory state. Cancer, high inflammatory state. Right? So those kind of things are going to increase your hepcidin. So labs, low iron, sure, elevated ferritin, you can go through those. At the bottom you can see there, usually normocytic, normochromic, but as it progresses. All right. It's anemia of chronic disease, so if you can identify what that disease is, right, you treat the underlying condition, then your anemia should improve. In severe cases, depending on what it is, right, what's ESA? Right, so something that's going to hit the bone marrow and hey, produce more. Right? A lot of times, sometimes it's like EPO even. Right? All right. So anemia of chronic disease, we'll talk about more when we hit the normocytic stuff. But just realize high inflammation state is going to drive your hepcidin up. It's just going to reduce the body's availability to iron. And you can work your chart across. Right? So low iron in the serum because the hepcidin shut that door. So your iron in the serum, right, serum iron decreases. Ferritin is your storage. Whatever storage you had is there, right? So your storage is still normal. There's iron floating there, right? It's just not in the serum. And then your transferrin, the body wants less, right? The body's kind of shut the door on it at that stage. And again, we'll dig into this when we hit the normocytic anemias and then the overlap. How we doing? Everybody alive-ish? Anybody need a break yet? I see some head nods. You guys want to take 10 and then we'll restart. What do you guys got after this? EMED. Well, that's a fun course. Who would stay for EMED? What? You guys don't like EMED? Hey, so during the break, one of your super smart peers in here asked me about RDW. So what's the RDW? What does that tell you? Variability, right? So we're talking about endocytosis. So if I had an elevated RDW, that's indicated what? Endocytosis. All right, so hey, the mic, if I write on the board over there, can you guys see? I haven't figured out how to write up on the board. So we said the problem was what with all the microcytic anemias? Where's the problem set? Hemoglobin. Something's wrong with the hemoglobin, right? So, can't see? How about now? Better? I guess you guys are just gonna have to miss this question on this. So right, hemoglobin, right? And what do you say hemoglobin's made of? So your heme group, right, which is iron and what? Iron, what's the other one? The protoporphyrin ring, right? And then your globin chains. What's your globin chains? Alpha. Right, your alpha and your beta, right? All right. So somewhere in here, if you guys can read this, right, is your problem set with any of the microcytic anemias, right? So the iron, obviously, iron deficiency is my problem set, right? When we talk about the thalassemias, the problem set is here, one of these two, right? And then we're going to talk about sideroblastic anemia. Your problem set is here, your protoporphyrin ring. I think everybody can use their imagination. Right? So this, again, just go back to when microcytic anemias. What's the problem set? The problem set is hemoglobin. Think of what makes up my hemoglobin, and one of these areas is where you're going to find the problem set.
So the RDW would not at all pertain to any of those because it's not dealing with the actual size.
Correct. RDW is something you're going to get on a. So if you, again, depending on where you run your CBC at, like most hospitals, right? If your hospital, the machine is fairly whatever, you're going to get an RDW. Right? So next to you, like your MCB, MCH, all that, somewhere there's going to be a little thing that says RDW. And for you, that's going to be an indication of anesocytosis. Right? So if it's super elevated, I might think, hey, is there some anesocytosis going on? But aside like that, right? So when depending on the hospital, some hospitals, right, they have the labs have their own parameters where they're going to do a manual diff if something's going to trigger it. Right, the white count is so high, or there's so much whatever, right? They all have their own parameters set up where they're going to trigger a manual differential. If you think you need a differential and you're not getting one, what are you going to do? You're going to order one, right? And now you just order a manual diff. And that's where too will confirm your endocytosis, because somebody's going to visualize those size of those cells, right? But your RDW is your clue to endocytosis. All right. So the hemoglobin, this thing, microcytic anemias. We're still on the microcytic anemias, and now we're moving to sideroblastic anemia. And we said the problem set is where Oh shit, you guys can't see that, huh? Alright. My bad. Yeah, so the problem set for the sideroblastic anemia is gonna be the protoporphyrin, right? There's your structure, right? So typical hemoglobin, your heme, right, your iron, that's your protoporphyrin ring with the iron bound to it in the middle, and that's your heme group. So somewhere in there, when we talk about this next set, that's your problem set. All right. Period synthesis, mitochondrial, yep. Defective incorporation of iron. Right? Because something's wrong with that protoporphyrin ring, it can't properly incorporate iron. So if you can't incorporate iron sufficiently, you're not making good hemoglobin. Not making good hemoglobin, I'm becoming anemic. Tracking? Good to go. All right. Bone marrow produces ring sideroblasts. Ring sideroblasts, right? So that's a classic finding. But that is not something you're going to see on your peripheral smear. That's something you see in the bone marrow. So that means something would have had to happen for me to go order a bone marrow on somebody. Right? Because that's not a routine test you're going to order every day, right? Because bone marrow sucks, right? It hurts, not fun for your patient. Basophilic stippling, picture of that coming up, you'll see those. Right? Basophilic presence of basophilic, you'll see this with sideroblastic anemia. You'll see this with some other conditions also. We'll talk about those too. But just means, hey, something not right with the erythropoiesis. If I see basophilic stippling, something's going on with that cell. I know it wasn't right. In this case, the iron wasn't processed sufficiently. All right. What causes sideroblastic anemia? Majority of the time it's acquired. Right? So alcohol can. Isoniazid, what do we give isoniazid for? Right? So drugs, toxins, lead poisoning, zinc overdose, some nutritional deficiencies, or in some cases it's an inherited problem. So if it's an acquired problem, that says, hey, if I can figure out what the problem set is, I can probably reverse it. Presentation, sure. But again, it varies, right, depending on the cause. But you guys have all seen this a million times by now, right? All these anemias kind of present the same. All right, there you go. Lab findings. Right, we're talking about microcytic anemias here. MCV could also be normal, could also be high. Retics. Retics causing some problems there. What's the retic? Immature, right? And RBCs, right, they get smaller as they mature. So a machine reading that is going to read that as a normal red cell size, potentially. Dimorphism, you get a normocytic microcytic, you can have two populations. So some of the cells look pretty normal, and then a lot of cells are microcytic. And that's what that's referring to there. Okay. So this is a disease process, right? Some variability with that MCV. Typically a microcytic condition. We treat it as a microcytic anemia, but that MCV could fool you a little bit depending on where they are in the disease process. Studies, right? There's some wonderful iron studies if you need them. Right. We said here the problem set was we're not incorporating iron properly. All right, so let's talk about the picture here. Ring sideroblast. That's that Prussian blue stain. Like the pants used to love to ask questions about like some Prussian blue stain stuff. Right. Prussian blue stain, ring sideroblast. You get a picture like that with anything on your pants, sideroblastic anemia. Right? Basophilic stippling. Again, it just says there's some ineffective erythropoiesis going on. It's an indication that there's something wrong. And what's wrong here is the body doesn't have the ability to properly incorporate iron. All right, management. Sure.
I have a question about an alcoholic who would have sideroblastic anemia. Wouldn't he also have iron deficiency anemia? Because of his
Wait, you gotta go slow. I'm old and slow. So they, oh yeah, and you'll see, so a lot of, this is the thing, right, so we're kind of teaching a little bit textbook-ish here, right? For real world, hey, you can, just because you have one disease process doesn't mean you have a second one going on.
I guess my question is, which would manifest first? This one or the other one?
So the sideroblastic or the iron deficiency? So which would manifest first? Either way, the body's lacking the ability to incorporate it. So this one, in my mind, so even at one stage, let's say they had enough iron, the body couldn't incorporate it, so this would probably show itself. Right? Treat underlying conditions, right? So again, any of these things where, hey, if you know what the problem set is and you can treat the problem set, things should improve, right? Inherited B6, or the inherited conditions. And part of that is the enzyme that works with the whole corporation. Part of it is a B enzyme. So by giving it B6, it fixes the problem set in the inherited cases. Transfusion, sure, if it's bad enough, they may need a transfusion. Treatment goals, prevent organ damage, right? So the body can't incorporate all this iron sufficiently. Iron is toxic to the body. Iron stored in the wrong places is bad. And we'll talk about that when we talk about hemochromatosis, right? So iron overload states can develop. Yeah, sideroblastic anemia in a nutshell, one slide, there it is. That's the whole lecture there, boom, done, right? So again, the ALA synthesis, right? So that's going back to that paradoxine, that'll fix that problem set. But defective heme, increased RDW, you get the dimorphic, some big, some not. What else you need? Ring sideroblast, diagnostic, right? And sure, bronze skin, and we'll talk about this because this picture here is a hemochromatosis picture. That's an iron overload state that's describing over here. So basophilic sniffling, Prussian blue stains, ring sideroblast.
Question for you, sir, regarding vitamin B6. So on the slide, you mentioned it's for inherited cases. Would you also supplement that for some of the acquired ones until it resolves? Like, even if you were to stop the alcohol?
It wouldn't help necessarily the acquired ones, right? Because the problem set with the B6 is a specific enzyme that the body uses, right? And it needs that B6 to incorporate, and the inherited is that they're lacking that enzyme. The B6 fixes that, but it doesn't fix the other problems. Right? So it works for the inherited, but it wouldn't work for any of the acquired conditions. Right? Right. So the other side, you had the iron studies on there, sure, but nobody really cares when it comes to sideroblastic anemia, right? Because how are you going to make your diagnosis ultimately? Bone marrow. Bone marrow. All right, moving on. Lead poisoning. Any questions on sideroblastic anemia first? All right. So again, protoporphyrin can't incorporate heme. I get heme everywhere. I can't get the iron where it needs to be. All right. Pathphys, lead. Again, lead inhibits heme synthesis. And as a secondary, also increases the rate of destruction of your RBCs. So your RBCs don't live as long as they normally do, right? So again, sets you up to be anemic. Microcytic anemia, again with the basophilic stiffness. Sources of exposure, right? So somebody's gotten high levels of lead, you're gonna say, hey, where are they getting this from? Where's this coming from? Right? It's not a normal thing. They're probably not consuming it, at least they have. And said, so when I just came into the military, anybody Cherry Point? I got Marine here. Cherry Point, over there. So Cherry Point, Marine Corps Air Station, yada yada, all right, E4, E5, or whatever the hell that was at the time, living in housing. All the housing there at the time, which they've since all destroyed and built nice new thing, right? Because they're all left over from World War II, all with lead paint on the walls, right? So all the kids in the neighborhood are peeling the paint and eating it because lead paint tastes hot. What does lead taste like? Sweet. Sweet. It's bad that you know that. Hold on. But it's sweet. So all the kids are like, friggin' peeling the paint and eating it. Right? So figure 20 years from now, like, you see that North, was it Camp Lejeune, water, whatever, killing people, right? I expect to see something from like Cherry Point, like 20 years from now too. But indoor ranges, right? Military, we ever handled stuff like this? Yeah, all right. So again, I spend a lot of time with the SF teams. A bunch of my dudes, I have to check them for lead, right? Because when you are sitting on a range for a week at a time, right, and doing nothing but 8 hours a day, right, firing down range, which we did often and fun until you get like a callous finger, you're doing it so much that you don't even want to shoot anymore, right? But again, exposures, right? So again, think of our population. Symptoms: fatigue, shortness of breath, tachycardia, yes. Abdominal pain, a lot of times lead poisoning presents with GI problems, right? GI problems, abdominal, constipation. Musculoskeletal symptoms, and then neuropsychiatric stuff, right? Irritability, learning difficulties, and that's why too, developmental things with kids are like, oh crap, right? Did I just set this kid back for the rest of his life? Because he was like, yep, I need to just feel some pain, chip away at it and snack on it because it was a nice candy for me for the day, right? But these can be lifelong issues sometimes. Labs, so do you normally order a lead on anybody? Right, so there's gotta be something going on to give you a reason to suspect, man, I need to take this off the table, right? So some of our operators, right, just because of the amount of stuff they handle, I'd get like annual lead levels on them to track them, especially if I saw them spiking, right? So again, think of your populations. Am I dealing with a trigger puller who's like living in this? Or am I dealing with a nerdy lab tech, right? Who's, all right, not a nerdy, just a lab tech. Am I dealing with somebody who's isn't exposed to that sort of thing? Or is the exposure someplace else? All right, so you have to think about the patient populations. All right, workup. Signs of anemia, right? Kidney function tests. Basophilic stippling. So if I ordered a CBC on somebody, I got some basophilic stippling, is there something else going on in my differential that I say I need to take lead off the table? Sorry.
The sideroblastic anemia?
So sideroblastic anemia, you'll see basophilic stippling, that's a consideration if I have lead. Because lead poisoning can cause sideroblastic anemia. These conditions we talk about, microhypo, Prussian blue, right? So again, presents a lot like the sideroblastic anemia, because one of the causes of sideroblastic anemia is lead, right? All right, management, sure. ID the source. When possible, obviously you want to figure out what the source is. What are they being exposed to so I can stop that, right? Because if you're treating somebody and they're still every day getting exposed to the same source, are you solving the problem set? Probably not, right? So remove the source and then chelation therapy. Easy day. Iron, sideroblastic anemia with a similar-ish. Right? Any questions? No questions. What is wrong with you guys? All right. Thalassemia. Where did we say the problem set was with the hemoglobin? In the globin chains, right? Those polypeptides, alpha or beta, take your pick, right? All right. Inherited group of disorders, absent production of or reduced. So again, the problem set is the hemoglobin. Genetic, yes. Globulin chain synthesis, yes. You guys already know this. Alpha, beta, you know this. Right? So because I have a problem with one of the globulins, whether it's the alpha or the beta, I'm not making normal hemoglobin. Not making normal hemoglobin, guess what? I become anemic, right? You guys got this memorized? You can reproduce this on a test. Yes? No? All right. It is, all right. So what we're talking about, right? Hemoglobin A, right? Adult hemoglobin, which is 97 to 99% of your hemoglobin. right? Once you're an adult, once you're out of the womb, pretty much, right, is where you're at. All right. So the thalassemias, it's a trait. We'll talk about all of these. When lab features, right, they're laboratory, so they'll show up on a lab test, but usually the patient is asymptomatic, right? They just have a trait. Intermediate, they can have some symptoms, and major is the bad stuff, right? We'll talk about hydrops fatalis specifically. So this is a little bit, this top trait, intermediate, major, is a little bit of an old verbiage, right? A lot of people now will use transfusion dependent versus non-transfusion dependent. Obviously, the more severe cases, the transfusion dependent ones. But that's kind of more up-to-date terminology. All right, so alpha, gene deletion. There's a gene deletion, right, inherited problem, so this one's a gene deletion, messes up your alpha globulin chain, boom, and now I got thalassemia, right, I got alpha thalassemia. In the presence of reduced alpha chains, excess beta, got it, problem with the cell, you get hemolysis, right? Prevalent in certain populations. So let's go through this a little bit. All right. So we have 4 genes for alpha, that codes for alpha. So normal, hey, I got all 4, I'm good, that's stone cold normal. I'm missing 1, you're a silent carrier. Right? Now I'm missing 2, I got thalassemia minor. Patients tend to start to maybe have some symptoms, but do okay generally. Now I'm missing 3, hemoglobin H disease, not good. Right? And then, in the worst case scenario, hydrops fatalis, which is almost always fatal in utero. Okay. Beta thal, again, prevalent in certain populations. This one is a point mutation, right? The other one was a gene deletion. This is a point mutation. Boom. All right. Let's go through this one. Beta. So you have, again, highly variable depending on the gene deletions, right? What combination thereof. And you can see what normal looks like. If it's heterozygous, I'm good. Right? When I get down to thalassemia intermedia, my hemoglobin A is now 30%. So yeah, I might need a transfusion if my hemoglobin, right? The majority of my hemoglobin is non-functional. Cooley's anemia, right? You can kind of see here, 0 to 10% normal hemoglobin A. So thalassemias, alpha, beta, take your pick, right? Problem with one of the two. And just depending on how many gene deletions, right, how severe it is going to tell you. Right? At the end of the day, do they require a bunch of transfusions? Or are they like silent carrier states? Signs, symptoms. Yep, you got a hemolytic, right? The hemoglobin is unstable, so you end up lysing. It's the hemoglobin in the system. What's a physical manifestation of hemolysis? Jaundice. That's the one I think of, right? Jaundice. And now, signs, symptoms of extramedullary hematopoiesis. So the body's trying to catch up. It's trying to kick out cells. The bone marrow says, hey, bone marrow isn't doing a good enough job. So now guess what? Spleen kicks in, liver kicks in, right? And they get that abdominal fullness. Beta thal. So this chipmunk facies, right? So we talk about secondary. So sometimes like the bone marrow in the skull can kick in. Sometimes other areas, the bone marrow will try to work hard to expand it, and you get these abnormalities that you get with beta thal. That chipmunk face. Right? Again, lung bone fractures impaired. GI tract issues, sure, leads to iron overload. And a lot of this is because of the repeated transfusions. So sometimes with your beta thal patients, you have to be careful because you can set them up for iron overload because they require these frequent transfusions. So every time they're getting transfused, right, they're getting iron automatically with the transfusion. Peripheral CBC, you guys notice, peripheral target cells, maybe some NRBCs. All right. Iron studies start to show iron overload states. And then the confirmatory tests. What's your confirmatory test? Hemoglobin electrophoresis. Hallmark of the disease, microcytic hypochromic anemia, right? Very small cells, and you always to say, the amount of MCV, right, is out of proportion to the amount of anemia. The cells tend to be very, very small with the thalassemias. So if I just say, hey, you have an Asian female, her hemoglobin came back low, what's the first thing you're thinking? Iron, right? Because all iron deficient, I got a microcytic anemia, my number one is iron. And what I've seen happen sometimes is people take these people with thalassemia and say, yeah, it's iron, and they don't do their full work, and let me go ahead and get an iron study to confirm, and they start them on iron, right? And then you don't see that patient, or they don't see that patient because guess what? They just deployed, and now you inherited their panel, and you got this patient who's on iron. You're like, why is this patient on iron? Oh, I see why they started them. Their stuff was low, and now you redraw their iron, right? You redraw their CBC, and guess what? Did the anemia get any better? It didn't get any better. Now you got this patient on iron, somebody else started on iron, they're not getting better. Are you taking your meds? And they look at you and say yes, and you say no, you're not, you're lying, right? Because I don't trust my patients, they're all lying. No, you gotta figure it out, why, what's going on? Maybe they are taking their iron, right? But was the right diagnosis made up front, right? So trust your colleagues, but verify. So if you go back to that patient's chart and you go looking for your iron studies to confirm that they're truly iron deficient, and you can't find your iron studies, what are you gonna do? You're gonna order your iron studies, right? So just think about that, because I've seen that happen, where patients with thalassemia, people say, oh, must be iron deficiency anemia, started them on iron, never took that added step to actually order the iron studies, and you wonder why this patient isn't getting better. All right, normal to elevated retic. Why the elevated retic? Right, hemolysis is taking place, right? So the body's trying to compensate. And then your hemolysis labs. LDH does what in hemolysis? Increase. Indirect bilirubin does what? Haptoglobin? Decrease, all right. Additional diagnostic findings, sure. Microcytosis disproportionate to the degree of anemia. So in the right population, or even the wrong population, right, because trust nothing, you never know somebody's, makeup, right, because we tend to Asian populations, Mediterranean populations, I don't know, right? And then these are just some of the other findings. So positive family history, sure. Again, getting a good history. Yeah, guess what? My so-and-so had, yeah, well, guess what? You might have it too then, right? So again, asking the questions. The normal cells, there's your target cells, your normal RBC, and then acanthocytes. Management, mild thalassemias, alpha, beta, typically no treatment. And you saw for the most part, if they're just missing one or the combination thereof wasn't severe, right? A lot of them were completely asymptomatic, right? Carrier states versus actually requiring transfusions or requiring therapy. More severe, so the hemoglobin H, those intermediate, do they need chronic transfusions? If you're getting chronic transfusions, you have to worry about iron. So they put them on some sort of iron chelated agent to make sure they don't develop an iron overload. Folic acid supplements. Why folic acid? We haven't talked about the macrocytic stuff yet, but why folic acid? You need to make red blood cells, right? So these high turnover states, you need those nutrients to make your RBCs. Avoid the oxidative drugs, sure, right? Avoid medicinal iron. They're already set up for iron overload states, and if I'm giving them iron supplementation on top of it, right? Especially, hey, I made the wrong diagnosis. I thought this was an iron deficiency anemia, but it really wasn't, right? And you see where I'm actually doing harm to my patient now by giving them iron. So last thing, very severe potential bone marrow transport, sure. Hemoglobin H disease, yes, any of these things, right, can be a precipitating problem for these patients. So a patient that you don't even know necessarily was diagnosed with any of these things. And do we ever use any of these drugs? Aspirin, doxycycline, Cipro, Macrobid, INH, right? Any of this stuff, the fava beans we'll talk about with G6PD, but any of this could precipitate a reaction in these patients. Mensur index, oh man, all right. Calculation, differentiate. Okay, so the key to this is this calculation here. All right. So MCV divided by your RBCs. If it's less than 13, you're dealing with beta thal. If it's not less than 13, if it's greater, it's iron deficiency anemia. So if you're kind of looking at your studies and you're trying to say, is it this or is it that? This can sort of be the tiebreaker for you and help you to get different. Insert index. It exists. I've never used it in my entire life, but it exists. Thalassemias. All right, so alpha, yep, Asian African we talked about. Decreased alpha chain production. Yep, the severe, right? The hydrops fatalis or the hemoglobin H disease. Those are the last two on the list there.
Sir, would the Mensur index be something that the lab would provide you with, or is that on you to calculate if you really want to know?
That's on you.
Okay,
We own that one if we want it.
thank you.
Yes, ma'am. And beta thal, certain populations, point mutations, right? The more severe one, the transfusion dependent, the Cooley's anemia. That one too, because they require a lot of transfusions, a lot of times, those are the ones that end up with the iron overload. How do you treat the iron overload? Chelated agents. Right? So the chipmunk faces because you have this extramedullary hematopoiesis going on.
Is gene transcription like the most definitive way to figure it out, or
Gene.
like for like
Oh, right. So if you want
alpha
to
versus
differentiate.
beta? Yeah.
Yeah, and even when you do the hemoglobin electrophoresis, depending on the amount, I used to have a slide in here that showed it. It can kind of give you an idea where you're at, but that would be the most accurate way. Genetic. All right, there's your summary slide for your thalassemias, right? Hemoglobin H, hydrops fatalis, otherwise known as Bart's hemoglobin. That's another term you'll see associated with hydrops fatalis. Bart's hemoglobin. Pans loves that one too. Silent carrier states, and then the beta thal, the Cooley's anemia. Iron chelation therapy, iron overload. All right, good. And then for us, your confirmatory test for thalassemia is what?
Most classic and most common.
The most common, where are we at? Yellow. Yeah. So most common is like, what are you gonna see the majority of the time? And then classic presentation is, in this case, the silent carrier state they're saying. All right, so classic, the patient that you're gonna probably run into, all right, most common, and a lot of these too, like hemoglobin H disease, might be the most common mutation, but these patients are sickly. Like a lot of them, the tendon might not make it, and this is what you're gonna run into. That's your classic presentation. So the majority of the time, the patient that you're gonna see is the silent carrier state. So even like hydroxytalis, right? Fairly out there. Are you gonna ever see hydroxytalis? Not, the patient isn't gonna make it. They talk about that. You'll read some studies where they talk about like trying to do in utero transfusions. Like, you're not gonna see hydroxytalis. All right, last, so this had to get added to it because parents decided to add hemochromatosis to their blueprint like last year. So you guys get to enjoy some hemochromatosis with me. So what's hemochromatosis? Anybody know offhand? Iron overload, right? All right, genetic disorder. Yeah, and we'll talk about this, right? You have a bunch of different states. We'll talk about the classic hemochromatosis here in a second. So you can kind of see tissue, sure, iron toxicity. Women present later in life. Why? Because early on, they're menstruating, right? So they're losing the iron, so it isn't showing itself. They stop menstruating, well, guess what? Now they're not losing the iron has time to accumulate. Now it presents. So a bunch of different types. This is the first one is the one to be conservative. Everything else in this lecture, we're going to talk about, what we're talking about is classic, right, hemochromatosis. Just for your essay, you got a bunch of other types out there. Right? All right, classic, hereditary, yeah, most common form, got it. Excessive iron absorption. So we'll talk about this in a second with your hepcidin. What does your hepcidin do? Yeah. So is your hepcidin high or low in these disease states? Low. And it's just letting the iron through. Secondary causes, right? Even when we talk about like beta thal there for a second, right? You can lead to a secondary type of hemochromatosis. All right. Paths, there it is, sure, inherited disorder, yep. Absorption of iron in the intestine, you guys know that already. Yep, not working. And then the iron, this excess iron accumulates everywhere. And I mean everywhere, right? Liver, pancreas, heart, skin, you name it. So it's gonna manifest, usually it's multi-system, right? And we'll talk about the manifestations. Typically men later in life, right, all the years of building up iron, and then women after menopause, we talked about. Liver, hepatomegaly, cirrhosis, sure, pancreas. Affect my pancreas, what else is my pancreas responsible for? Insulin and everything. So do I now develop diabetes because my pancreas is all messed up? Bronze diabetes, why the bronze? Because it also affects your skin too, right? And heart, cardiomyopathies, skin, the hyperpigmentation. Right? Again, iron is getting everywhere. Joints, develop arthritic conditions. This does not sound like a fun disorder to have. All right, you got 5 seconds. Everybody memorize this. Boom, right? Again, the iron can deposit anywhere. So you start thinking of all the associated things depending on the system that it's affected. Abdominal pain, arthralgias, ascites, cardiomyopathies, right? So again, this is one of these disorders where you have to have a high index of suspicion about, and something has to be triggering you, because I look at this could be anything, right? Loss of libido, lethargy, testicular atrophy, weakness, right? Hypothyroidism, I mean, you name it, nothing gets untouched here. Right? That's kind of the layout. So hemochromatosis, iron overload state. If you have an iron overload, is your iron high or low? High. Iron's obviously high. Your storage becomes high. We said that your hepcidin is what? Low, so we're letting the iron in, so your transferrin is saturated. Right, so that's the result. Make sense? Everybody good with that? All right, hemochromatosis. There it is, your bronze diabetes. That's sort of one of the classic questions, right? So hey, iron overload, your hepcidin is low, it's letting all the iron through, you're not regulating iron properly, you end up with excess iron. The iron gets deposited every which way you can think of, so it starts affecting all those different organ systems. So you can start thinking about what problem sets would occur. If it's deposited into the heart, do they develop a cardiomyopathy? Do they develop an arrhythmia? Right? If it's deposited in your testes, right? Do I now develop hypogonadism, impotence? If it's affecting my thyroid, am I hypothyroid or hypothyroid, right? So you can kind of see and you can kind of work through this, and it can affect anything and everywhere. Ends up in your joints, ends up in your pancreas, right? All of a sudden, the patient that you're not suspecting of a whole lot, you get this weird, all of a sudden they're diabetic, and you're like, where's this coming from? And I don't think twice when I see a diabetic patient, right? Because every other people you walk into in this country is diabetic, right? You're gonna figure that out real quick in all your labs. You're gonna see diabetes, high cholesterol, all along, just day after day. But is that indicative of something else going on? Right? So do I need to do other studies? Diagnosis, history, physical, right? We know this. Your iron studies. So with hemochromatosis, it's an iron overload state, so everything is high. Genetic testing. So if I get to this stage where like pretty sure this person has hemochromatosis, then I'm going to want to confirm genetically to make sure of the type. Right? And this one that we talked about, the classic, right, is the genetic one. Liver biopsies. So these patients, a lot of times, will end up with like cirrhosis or go on to have liver cancer. So liver biopsies. Imaging, CT, MRI, right? These are more high-fangled stuff. But early on, it's capturing it, being suspicious, something on your lab, something in the patient kicked you off that made you suspicious enough that now I got my iron studies. I get iron studies like that, and I'm like, oh yeah, there's a problem here. Right? There's an iron overload, and now you gotta go figure out why. Management. Regular phlebotomy. Go get your blood drawn, let's tap off. Right? And then iron chelation therapy. Any of the overloads, right? Chelation therapy. Dietary modification, sure. Monitoring, sure. All right, there's your hemochromatosis in a nutshell. Right. Increased intestinal iron absorption. Why? Because my hepcidin is low, so I'm letting all the iron in, right? Flooding my system, and it's getting deposited everywhere. The fact that it's getting deposited everywhere, not good, right? And then to treat, phlebotomy, chelation therapy, diagnosis, yep, LFTs, worry about the liver a lot in this disease, because again, they have a lot of liver issues, including progressing to liver cirrhosis, fibrosis, and cancer. Men more so than women, sure, and women tend to present later in life because of, all right, there's more wonderful summaries on these sides. Classic, right? This is what we're talking about. So phlebotomy, yep. Fibrosis, cardiac function, yep, all the usual. Any questions on hemochromatosis? Iron overload state. How about sideroblastic anemia? Lead poisoning? Going once. Iron deficiency anemia? All right, hey, so there's a couple of things to keep in mind as you guys review your notes, right? Really understand the relationship between hepcidin and these disease processes. And then be able to talk yourself through, if I got a patient with X presenting with this, and I get a set of labs, right? I get my iron studies, where am I going? Right? Be able to put those together to synthesize, to come up with a diagnosis and come up with a treatment plan. Other thing to pay attention to as you study, confirmatory tests. I suspect this, how am I gonna prove it? Right? Everybody good? Don't lie to me. Don't lie to me. The last class did the same thing until the test showed up. They're like, huh? Bunch of vignettes, right? You gotta be able to read through a problem set. And I won't lie to you, right? Some of the vignettes may have some extraneous information that you don't even care about, but I put it in there. Right? So you gotta just pick out what's important. Alright, no questions? Enjoy the rest of your ER. And next class, when I have